Hello, and thank you for joining us for this peer exchange entitled Optimizing Outcomes in the Treatment of HIV. Substantial advances have been made in using antiretroviral therapy for prevention and treatment of HIV infection. Newly available regimens are safer, more effective, and more convenient than ever before. I'm joined by a panel of infectious disease specialists who are experts in treating HIV infection. Together, we're going to talk about the most recent recommendations for long-term management of your patients who are at risk or are already infected with HIV. In addition, we're going to talk about emerging agents that are coming to the clinic soon. I'm Dr. Peter Salgo. I'm a professor of medicine and anesthesiology at Columbia University College of Physicians and Surgeons and an associate director of surgical intensive care at New York Presbyterian Hospital. Joining me for this discussion are Dr. Eric Daar, chief of the Division of HIV Medicine at Harbor UCLA Medical Center and professor of medicine at the David Geffen School of Medicine at UCLA in Los Angeles, California. Dr. Joseph Eron, professor of medicine at the University of North Carolina, Chapel Hill in North Carolina. Dr. Ian Frank, professor of medicine at the University of Pennsylvania in Philadelphia. And Dr. Paul Sachs, clinical director for the Division of Infectious Disease at Brigham and Women's Hospital and professor of medicine at Harvard Medical School in Boston, Massachusetts. Guys, thank you for joining. I know it's not sexist because you are, all guys. I want to thank you, and I'm going to start right now with our first question, which is the obvious one. What are the most recent recommendations for HIV screening? Who wants to start us off, Ian?
I can start us off.
Sure.
So the CDC has created some guidance for HIV testing in the United States. They recommend that everybody between the ages of 13 and 64 be tested for HIV at least one time if you live in a neighborhood where the HIV prevalence is not less than 0.1%, which I don't think exists in the United States.
You know, for me, as somebody who was in practice at the beginning of the HIV epidemic, which wasn't an HIV epidemic then, it was whatever you wanted to call it, that's an astounding statement. Basically, they want to test everybody. Why?
Well, there are a couple of reasons why the CDC decided to do that. One of them is obvious, which is that you want to be able to find people who are infected before they get sick. And that way they can get life-saving therapy and not transmit the virus to other people. But the other reason they did it was actually kind of more psychological. They said that if we test everyone, the stigma around getting tested will be reduced. And that has actually been very effective because when you look at actually case finding, it's more important to test high-risk people than it is to test just everybody. So this was kind of a destigmatizing effort by the CDC.
Well, I remember that in the early days, you would say, well, I know who to test. I can
Sure,
tell.
right. We don't know who to test.
You never
right.
knew.
We don't know who to test. And their range is a little funny, like 64, like that's like a Beatles reference or something. It's not really clear why you should stop, because older people can get HIV. In fact, we're seeing that. But,
okay.
But I think Paul made a critical point, which is that people who are at highest risk need to be tested more often. And in fact, we were trying to get away from what's called targeted testing, but I think that's exactly what we need, actually. And that's what's missing. These younger people who don't touch healthcare, right? They're not in healthcare. They don't touch the system.
So let me put money on the table briefly. We'll take it off again. But if I'm going to screen everybody in the United States, which is effectively what I heard you say, is it cost effective?
Well, we have our cost-effective expert at the end
so
there.
it's cost-effective when you're testing people above a certain background prevalence.
But that's not what he said. He said pretty much everybody.
Yeah, I mean, the bottom line is that the test is very inexpensive, and the years of life saved from finding an undiagnosed case of HIV are so huge that it ends up being cost-effective. But that targeted testing is still really, really important.
And the other point, too, is that the tests are exquisitely sensitive and specific. So it's not like a test where you get a whole bunch of false positives and you waste a whole bunch of money doing prostate ultrasounds or something.
I was about to say, this isn't a PSA test.
Or this isn't Lyme disease testing. I mean, this is like to open a Pandora's box.
Let's close that one right away.
There's another benefit, though, that's really important, is it's not just for the individual, too. There's always been this concern that 15–20% of people in the United States are infected and don't know it, and that those people may be disproportionately driving the current epidemic as
now,
well.
let me just, I heard a number.
That number, though, is much improved compared to the number 5 years ago.
The number, right now, it's probably about 15% of the people infected in the United States don't know it.
That's
and the only reason they don't know it is because they've never been tested.
Okay. So again, you test everybody to avoid stigmatizing the people that you really should be testing more often.
That's true.
It's not a bad idea, frankly, if it's cheap.
Plus,
and
you also
it's
you
easy
do
to
find people, but it's just not a very efficient find. Like in North Carolina, like the number of tests increased by 2 to 2.5 fold, and the number of new diagnoses went up like 10%.
Yeah.
Right. But you do find people,
We-
and it's so valuable to find them. Right?
We did a study in our emergency room of testing people in whom testing would not otherwise be indicated. So we were actually screening everyone.
Right.
And the yield was understandably very low. We did find some. We found a few. Interestingly, we found a couple who were actually already known to be infected but had forgotten or were in denial.
Right.
So I mean,
There is a lot of denial.
it was actually quite useful.
All right, well, let me,
But I think before we move on, I think we should talk about who should be tested.
Well, that's- I
right?
wanna get
rather
there.
than just the test everybody, right?
well, that was my next question anyway, because you did allude to this, that there are some people that you really want to drill in on, if you will, high-risk individuals. How would you define those?
So I think we would define them as men who have sex with men, individuals with multiple concurrent sexual partners, individuals who do intravenous drugs, folks who have certain indicator diseases that can be associated with HIV that are often overlooked. Psoriasis, herpes zoster,
Right.
tuberculosis.
Zoster's a big one, right?
Zoster's a
The big
big
one.
one.
Oh yeah,
Yeah.
no, we just had a woman with zoster, a year ago, young woman, and came in HIV, low CD4 with PCP. Right.
Okay.
Anyone who's had a sexually transmitted
Right,
infection.
Thrombocytopenia. I mean, there are a whole bunch of conditions that normally are not thought to be HIV related and yet are early
So-
clues. Yeah.
De novo, so-called idiopathic thrombocytopenia, get an HIV test.
Absolutely.
Yeah, that should be unequivocally part of the workup.
All right, so those are your high-risk individuals. Of course, if you know that they're thrombocytopenic, you've tested them for something else anyway. Right, you wouldn't know.
Right. They've
Yeah.
had a blood work, but
Well, and the
go
current
ahead.
guidelines are targeting people who are encountering the healthcare system for other reasons.
Right, okay.
This is, certainly everyone's encouraged to seek out testing sites, but the guidelines are really focusing on people who encounter the healthcare system for any reason should be offered testing.
All right, now we have two kinds of compliance here, right? There's the compliance of people who present, I'd like to be tested, you offer them the test, you'd like them to take the test. And then you've got compliance for primary care physicians, other physicians who should be proactively offering it. So why don't we divide that into two groups? How do we get people to want to be tested? Anybody have a brilliant idea?
Well, I mean, you get the word out how effective therapy is, number one, right? Because, you add 30, 40 years of life to someone who's, 20 years old, who would, if they weren't treated or weren't diagnosed, might live 20 years, but can live 50 or 60 years instead, can essentially have a normal life expectancy. So that's I think, one obvious way. I think destigmatizing the test is really important.
In infectious disease practice, like the one we have, the way we do it is we say to people who come in who haven't been tested, we say, we test everyone.
Right.
And they go, okay, because they're everyone. They're part of that.
But does
part of
every
everyone.
doctor do that?
No.
Is it part and parcel of every doctor's practice?
But they can learn from us.
Well, that's what
Right,
we're doing
well, that's part of
here.
this, you're right, sure.
So the message, if I hear you correctly.
So the recommendations are over 10 years old.
Okay,
And clearly, everybody isn't doing it.
Yeah.
why not?
Well, it's sort of an unfunded mandate, if you will. There's no money that came with it.
Okay,
It takes a lot of effort, although they tried to make it easier. They got rid of the consent process, which was huge. All the pre and post-test counseling that used to take up a lot of time, they got rid of all of that. But not everybody has, the ability to spend the time with the patient and simply say, we're going to do this as part of routine care. And then the other big fear is dealing with the fallout when you find a positive. A lot of centers, whether it's a private doctor's office or even emergency departments, they got to move on to the next patient. They're not looking for new problems.
But I think some of it is just assumptions that we make. Oh, you've been taking care of this gentleman for many years, and you think you know who their sexual habits, and you say, oh, they're not at risk for HIV, and I think that's what happens. Like Paul said, if your approach is, we test everybody for HIV infection, when you're ordering any kind of test, routine blood work, you could say, hey, it's our standard practice to test everybody.
Okay.
The counseling doesn't need to be more complicated than that.
it's
it
like the
doesn't
old,
need to take a lot of time.
it's like the old SMA 20, if you're old enough to remember
Just
this.
check the
Everybody
box.
got the essay.
Yeah.
It was a crazy test, but everybody got it.